Hello everyone, and welcome to the Docsaab's diary. And today I am going to teach you about the CHA2DS2 score, and we will explore this essential tool used in modern cardiology. The CHA2DS2 score is a critical assessment for predicting stroke risk in patients with atrial fibrillation. This presentation will provide a comprehensive overview from its fundamental purpose to its practical application in clinical settings. By the end, you will understand how this score guides treatment decisions and improves patient outcomes. Let's begin by establishing a foundational understanding of what the CHA2DS2 score truly is. At its core, it's a clinical prediction rule meticulously designed to estimate the risk of ischemic stroke, specifically in patients who have non-valvular atrial fibrillation, a condition commonly referred to as AF. Its primary purpose is nothing short of life saving stroke risk assessment. As many of you know, atrial fibrillation is a condition where the heart's upper chamber beat irregularly, which can lead to blood pooling and the formation of clots within the heart. These clots can then dislodge, travel to the brain, and cause a devastating ischemic stroke. The CHA2DS2 score is our critical compass, helping us pinpoint which patients are at higher risk of this event. The practical application of this score is profoundly crucial because it directly guides antithrombotic therapy decisions. By accurately stratifying patients into various risk categories, low, intermediate, or high, clinicians gain the precise insight needed to determine whether blood thinning medications, specifically oral anticoagulants, are necessary to prevent a stroke. It's important to understand that CHA2DS2 score wasn't born in a vacuum. It's evolved from an earlier, somewhat simpler score known as CHA2DS2. The key improvement with CHA2DS2 lies in its enhanced ability to stratify risk with far greater precision. This is particularly evident in its capacity to identify those patients who are considered truly low risk, meaning they may not actually require the risk associated with the long-term anticoagulation. Finally, this score holds immense global recognition. It is widely recommended and endorsed by virtually all major medical organizations across the globe, including highly influential bodies such as the American Heart Association, the American College of Cardiology, and the European Society of Cardiology. The CHA2DS2 acronym is far more than just a string of letters. It represents a carefully selected collection of clinical risk factors, each of which has been assigned specific points based on its contribution to stroke risk. Now, let's methodically break down each component, understanding what it signifies and its associated point value. C stands for congestive heart failure, or more specifically, evidence of left ventricular dysfunction. This factor contributes 1 point to the overall score. H represents hypertension, defined either as documented history of high blood pressure or the patient currently being on treatment for it. This also adds 1 point. A2 is a critical factor signifying age 75 years or older. This age group carries a significantly higher stroke risk, so this factor rightly contributes 2 points, reflecting its elevated weight in the assessment. D is for diabetes mellitus, which adds 1 point to the score. S2 stands for high history of stroke, a transient ischemic attack, or any prior thromboembolism. This is another high impact factor, scoring 2 points because a previous event indicates a very high risk of recurrence. V represent vascular disease. This includes conditions such as prior myocardial infarction or peripheral artery disease or the presence of aortic plaque. This factor contributes 1 point. A signifies age 65 to 74 years. This is a distinct age category from A2 and adds 1 point to the score. And finally, SC stands for sex category, specifically being female. This adds 1 point. This inclusion reflects an observed tendency for women to have a higher stroke risk than men for the same total score in certain clinical context. Though this particular factor has been subject to considerable debate and recent guidelines updates, which we will discuss later. Calculating the CHA2DS2 score is remarkably straightforward, employing a simple and intuitive point-based system. The total score you can achieve ranges from a minimum of 0 to a maximum of 9 points. The method itself is a quite a logical. You systematically go through each risk factor we just discussed and assign the designated points for every factor that is present in the patient's medical history. Once you have meticulously identified all the applicable risk factors and assigned their respective point values, the next step is equally simple. You merely sum all these points together to arrive at the patient's final CHA2DS2 score. To truly illustrate this, let's walk through a practical example calculation together. Imagine a 76-year-old female patient. Her medical history includes hypertension and diabetes, but she has no other listed risk factors that fall within the CHA2DS2 criteria. First, for her age say more than 75, she clearly qualifies for 2 points. Next, for hypertension, she receives 1 point. For diabetes, she also gets 1 point. And finally, for her sex category, female, she adds another 1 point. Summing these up, 2 plus 1 plus 1 plus 1 equals a total score of 5. Now, it's exceptionally important to highlight a special consideration, particularly for a score of 1. If a patient's CHA2DS2 score is 1, but this point is only due to them being a female with no other risk factor present, their actual risk profile is often considered to be very low. In such specific scenarios, anticoagulation is typically not recommended. This showing the critical nuance in interpreting a score of 1, underscoring that treatment decisions are ultimately individualized and require careful clinical judgment, not just a numerical rally. Once calculated, the CHA2DS2 score transition from a mere numerical value into a powerful tool that is interpreted to assess the annual stroke risk, directly guiding crucial clinical decisions. Fundamentally, the score directly correlates with the approximate annual stroke risk. This means, quite simply, that a higher score indicates a progressively higher risk of experiencing a stroke within a year. Based on the total score obtained, patients are generally stratified into three primary categories for each of clinical management: low risk, intermediate risk, and high risk. While the specific percentages can vary slightly between different studies and cohorts, a general understanding of the approximate annual stroke risk associated with each score is absolutely crucial for proper interpretation. For instance, a score of 0 corresponds to a very low annual risk, often reported as nearly 0.2%. A score of 1 might indicate a risk of around 1.3%, and a score of 2 could be around 2.2%. You will notice that generally the risk increases with each additional point. These risk levels carry profound clinical implications for how we manage our patients. Patients with a score of 0 are considered truly low risk and significantly typically do not require anticoagulation. This avoids exposing them to unnecessary medication and its associated risk. For a score of 1, especially if that single point is solely due to female sex without other comorbidities, the decision for anticoagulation becomes highly individualized. It necessitates a careful weighing of the potential benefits of stroke prevention against the risk of bleeding. However, for scores of 2 or higher, the risk of stroke becomes significant enough that oral anticoagulation is strongly recommended. This intervention aims to prevent potential harm from a stroke, as the benefits generally outweigh the risk in this group. Understanding this critical nuance in risk stratification is a key to effective patient management and personalized care. Clinical guidelines from a major cardiology organization such as the American Heart Association, American College of Cardiology, and the European Society of Cardiology serve as the authoritative blueprints. They provide very clear and specific recommendations for antithrombotic therapy based directly on the calculated CHA2DS2 score. For what we define as low risk patient, typically males with a score of 0 or females with a score of 1, where that single point is attributed only to female sex with no other contributing factors, There is strong and consistent consensus across these guidelines for no antithrombotic therapy. This is a crucial point, preventing unnecessary medication. For patients falling into the intermediate risk category, which usually includes males with a score of 1 or females with a score of 2, the guidelines suggest careful consideration of anticoagulation. This particular decision making process often involves a comprehensive shared discussion with the patient, meticulously weighing the potential benefits of stroke prevention against the inherent risk of bleeding. It's highly individualized choice. Moving to high risk patients who are defined as males with a score of 2 or higher and females with a score of 3 or higher. There is very strong and unequivocal recommendation for initiating oral anticoagulation. In this patient population, the significant benefits of preventing a stroke generally and clearly outweigh the risk associated with the bleeding. Regarding the choice of anticoagulants, the landscape has significantly evolved. Direct oral anticoagulants are now unequivocally preferred over warfarin for the vast majority of patients. This preference is due to their improved safety profile, reduced need for frequent monitoring, and overall greater convenience for patients. Finally, it is critically important to remember that aspirin has a very limited role in the primary prevention of stroke for patients with atrial fibrillation. It is generally not recommended as monotherapy for this purpose, as its benefits are minimal compared to its bleeding risk in this specific context. The CHA2DS2 score is not just a tool, it offers several key advantages that profoundly impacts its utility and effectiveness in everyday clinical practice. Firstly, and major leap forward, it provides superior risk stratification compared to its predecessor, the CHA2DS2 score. By intelligently including a broader range of clinically relevant risk factors, the CHA2DS2 score allows for much more accurate identification of patients across the entire spectrum of stroke risk. A truly significant strength, and perhaps one of its most celebrated features, is its effectiveness in accurately identifying truly low risk patients. This means that clinicians can confidently determine which patients generally do not need anticoagulation. This is vital as it spares these individuals from unnecessary medication exposure, potential side effects, and the psychological burden of long term therapy. The score is lauded for being simple and remarkably easy to use in the hustle and bustle of daily clinical practice. Its straightforward point system allows for a quick and efficient calculation right at the point of care, fitting seamlessly into busy workflows. Furthermore, it impressively comprehensive by incorporating broader, more inclusive range of relevant risk factors. The scopes provide a much more nuanced and accurate assessment of patients' individual stroke risk than older, less detailed models. Lastly, a cornerstone of its reliability is that CHA2DS2 score has been widely validated across numerous robust studies and diverse patient population globally. Its consistent integration into major international clinical guidelines further underscores its proven reliability, widespread acceptance, and indispensable role within the medical community. These advantages collectively make it an indispensable asset in stroke prevention. Despite its widespread use and clear advantages, it is equally crucial to recognize that CHA2DS2 score, like any clinical tool, has certain inherent limitation and important consideration that clinician must be mindful of. Crucially, the CHA2DS2 score does not assess bleeding risk. This is completely separate yet equally vital assessment that must be performed. Typically, this is done using other delicate tools such as the has bled score. The bleeding risk assessment must always be considered in conjunction with the stroke risk when making the critical decision to initiate or withhold anticoagulation. There is also significant risk of overgeneralization if the score is applied too rigidly without careful consideration of the individual patient's complete clinical picture. Every patient is unique, and clinical judgment remains absolutely paramount, serving as the ultimate guide beyond the numerical score. A notable and ongoing controversy revolves around female sex as independent risk factor. This particular inclusion has led to considerable debates and, as we have seen, even direct changes in recent guidelines. In a significant development, the 2024 European Society of Cardiology guidelines have, in fact, shifted their recommendation to a CHA2DS2-VASc score. This new version specifically removes the point for female sex, aiming for more simplified, streamlined, and arguably more inclusive decision making, reflecting an evolving understanding of this risk factor. Furthermore, the score does not account for the quality of anticoagulation, particularly for patients on warfarin. For these individuals, adherence to medication and consistent INR control significantly impact the actual effectiveness of their therapy, a factor not captured by the score. Finally, there can be some variability in its predictive value across different population and ethnic groups. This highlights a continuous need for ongoing research and potential adaptation of the score to ensure its optimal utility globally. Understanding this limitation is a key to using the CHA2DS2-VASc score wisely and effectively. To bring our discussion to a concise and impactful close, let's revisit the key takeaways from today's presentation. First, remember that CHA2DS2-VASc score is vital and widely used tool that serves as the cornerstone for assessing stroke risk in patients diagnosed with atrial fibrillation. Its role in patient management cannot be overstated. Secondly, it plays a crucial role in guiding anticoagulant therapy by accurately stratifying risk. It helps us effectively prevent stroke and, importantly, its often debilitating and life-altering consequences. Thirdly, a thorough understanding of its components and accurate calculation is absolutely essential for proper and reliable risk stratification. The precision in its application directly translates to better patient care. Fourth, a clinical guidelines provide a clear and actionable recommendation based on the score, always integrated with the individual patient unique profile, thereby directing the most appropriate management strategies. And finally, awareness of both the advantages and the inherent limitation of the score is critical to ensure optimal, truly patient-centered care. This comprehensive understanding empowers clinicians to make highly informed decisions that delicately balance the imperative of stroke prevention with the crucial consideration of bleeding risks. This balance is at the heart of effective cardiovascular management. Thank you very much for your focused attention throughout this presentation. I sincerely hope that this session has provided you with a clear, comprehensive, and practical understanding of the CHA2DS2-VASc score and its profound importance in clinical practice. Please feel free to ask anything that comes to mind via comments, and I will do my best to address your queries. Please like, share, and subscribe to the Docsaab's Diary.